This is the third open house session for the National Health Stack, and it's a technology session. As we have been mentioning earlier, these sessions are still all tech sessions right now. My name is Sharad Sharma. I'm one of the volunteers at iSPIRT, and I'll be moderating the session today. We have two topics that we'll be covering. We'll be going deeper into the doctor registry today. And in fact, one set of APIs will be shared with you today. And that part of the discussion will be handled by Vikram Srinivasan. And Vikram is going to introduce himself before he starts, because this is the first time you're meeting him in these open house sessions. The second session is to continue to take more questions on PHR. And there's some very good questions that have come in, and they would be answered by Siddharth Shetty. You met him earlier. And then we'll conclude by announcing what the future sessions are going to be. And so that's really the plan. Let me get in and start moving my slides here. Just give me a minute to stop share and then come back. So as usual, many of you know about iSPIRT, so I don't need to do an introduction there. iSPIRT is really a tech think tank, a non-profit kind of a think tank, and which is driven by volunteers, and it is based on a concept of no greed, no glory volunteers. We see ourselves essentially as nation builders, and we believe in an innovation architecture for India, which is to say that India's hard problems can be solved only by a jugalbandi between public infrastructure, public digital infrastructure, and private innovation. So this is really our mantra. And as some of you must be noticing, I'm having some trouble getting my slides up. If I'm not able to make it work, I'm going to request one of my fellow panelists to flash the slides. And let's see if I can get them to work here. So that's a little bit about iSPIRT. With that, let's do a quick recap of the health stack again. We've been doing that in every of these sessions that we are covering. And the reason we are doing that is because there is a lot that has got to be covered, and it will take time for all this assimilation to happen. Many of you know that the health stack has been in the works since July of 2015. So this is not a new kind of a phenomena. And it has three layers, and the bottom layer, which is the plumbing layer, which is where most of our focus is at this point in time, is very important, and that is what is rolling out first. You also have an augmentation layer, and then a top layer, which is called Open Health Services Network. And the short form for this is OCEAN. We call it OCEAN. And right now, in the next few months, the focus is only going to be on teleconsultation. And you can extend that a little bit to OPD if you like, but it's essentially teleconsultation. And this is the layer that separates out what happens on the front end and what happens on the back end. So the front end apps, and many of them today, the front end and the back end are coupled with each other. In the future, the expectation is that they'll get separated. So there'll be many front-end apps. One of the reference apps, starter apps, will be the Swasth app, which will be announced by the Swasth Alliance, a separate group of people who are working to make healthcare better and using the health stack. So they'll announce the Swasth app in the coming weeks and days. So this is a very high level overview of the health stack. Now the question is, why is it the way it is, and how does it relate to what happens on the ground? So if you look at teleconsultation, currently, what we are in is a default scenario, and in this scenario, very often teleconsultation is free. It is paid by kickbacks, and this is not just true in India; it is also true in other parts of the world. The perception of telemedicine is that I take one of these, it's a way for me to get prescription for a drug, that I want, and therefore it's paid by the drug company, or by people who are promoting that drug. And so it's not trusted, and it becomes a source of very many referral fees. Patients see it as a racket, there isn't trust, and therefore the market doesn't grow. And this has been true even for e-commerce. And that's why we have very high percentage of cash on delivery, which makes, of course, it less viable in marginal markets in Bharat and so on and so forth. So in a way, the goal is to break this jinx that we have, and it needs to therefore start with some rules. And it is that the teleconsultation is paid. If you go to an OPT doctor, you'll pay for it. Teleconsultation is paid. You trust things that how are they being paid, right? So teleconsultation is paid. The providers on the back end, the networks of which the doctors hang off, they compete to provide the best service, and they get paid for it. And they look for scale, and they don't see the front end apps as a threat to the business, because they have to act in concert to grow the market. Patients learn to rely on teleconsultation, and they feel that it gives them actually a better doctor at a lower cost than an OPD visit, and hopefully even sooner than what they would be able to do in terms of accessing a OPD doctor. And so therefore, teleconsultation, the market grows in a big way. For this to happen, it is essential that trust gets built in the system. Now, trust cannot be built by marketing, as you know. Trust has to be built on authentic transactions, trustworthy transactions. And so therefore, standards of care have to emerge, and transparent business rules have to exist. And for standards of care to emerge, the health stack provides something called the protocol server, the doctor registry, which we'll be discussing today, and PHR, which we have discussed many times before. We'll be taking some questions on that today. These are all important building blocks for providing standards of care. But it also needs transparent business rules. And so these are enforced by the ocean layer, and they're also enabled by an auditable kind of a money settlement system. And this happens between the front-end apps and the back-end teleconsultation. So if you go back and look at the same health stack picture, the standard of care is provided by these three building blocks, 1, 2, and 3, the ones that you see here. And we've so far only been discussing 1 and 2. In the future open houses, as we go forward in the next few months, we will be discussing the protocol server as well. And the transparent business rules that we talked about are enabled by Ocean here, which is this layer, and also by a settlement system, an auditable settlement system that will come in. So these are also things that you will hear about as we go forward. So some of these dates are known, and I'm just kind of restating them again. The personal health record, the main thing, we continue to answer more questions. We're going to do that today again. And what you have to now next look at is the 30th June deadline, which is when the test environment will go live. We are on track for that, and we hope to cover this in our 27th June open house session. And in the doctor registry, we are releasing some of the APIs a little early today, and the next set, one remaining set of APIs, the enrollment APIs, will be announced in the next week's open house session. And the test environment was supposed to go live earlier. We got requests from many people who were waiting for the PHR that we should do it at the same time. There is no point staggering it. So that seems like a great suggestion. So we will also be unveiling the test environment for the doctor registry on 30th June. So this is a shift. This was supposed to be on 15th of June. We've, at the request of many players, moved this so that you are dealing with both the test environments at the same time frame, and that makes it easier. Ocean will happen a little later. You'll have to wait for this. The APIs and sample port will come only in July, towards the end of July. So this is a quick overview of the health stack. With that, let me request Vikram to come in. He'll pull up his slides. Vikram, I also request you to do a quick introduction of yourself. That'd be very helpful.
Sure. Thanks, Sharad. Thank you very much. So hi, folks. I'm Vikram. I've been a volunteer with iSPIRT for about over a year now. I've been working on several aspects of the health stack. My day job, I'm essentially, I've been an academic and I've been in the technology industry for about 20 years now. So with that, let me get started. So I hope you guys can see the screen. So I'll start talking about, I think Sharad covered the first few slides of the health stack and the roadmap. So I'll move on to the registries. So as we had mentioned earlier in the registries, there are several kinds of registries that we will be enabling. And all of this, the goal of all of this is to enable trust in the system, both in teleconsultation kind of scenarios and also offline scenarios. So a few examples of the registries we are trying to bring up. One is the facility registry, which is basically the data for all facilities that offer healthcare. These could be hospitals, these could be diagnostic labs, these could be small clinics, etc. Then we have the doctor registry, which is essentially information about all the doctors in the country. And the hope is that once we have this, we'll be able to verify that doctors are legitimate so that we have more trust in the system. And it'll also give a lot of interesting use cases for doctors, which we'll come to. And finally, there is the beneficiary registry. So basically, these are the beneficiaries of public health schemes like PMJAY, etc. So, um, so at the end of the day, if you think about who are the entities that need to be identified in a healthcare interaction, and some of this might be repetitive, but before going into the details of the APIs, I thought it would be good to quickly go cover this stuff. So the people who are essentially participants in the healthcare interaction is, of course, the individual, the care professional, care provider, the payers in the ecosystem, such as insurers, etc. All kinds of governing bodies. It could be a regulator, it could be uh, an insurance regulator, health regulator, etc. Research bodies, pharmaceuticals, and health and tech companies, right? So we need to sort of enable all these players who are in these interactions to understand what information to ensure that there is reliable and relevant information coming from each of these players as information flows through the system, which are a consequence of these health interactions, right? So that's what we're trying to enable with these registries. So what are the design principles for the registries? Sorry about that. So the design principles are fairly straightforward. We want them to be self-maintainable. Essentially what this means is that a doctor, for example, in a doctor registry has the ability to enroll themselves. So it's all self done. You don't necessarily require assistance to get onto these platforms or register yourself on these platforms. The data that is on there is completely non-repudiable, which means that once the data is, once you enroll yourself or you enter some data onto the system, this data, every element in this data that you upload, for example, your demographic information, your qualification information, what your registration, etc., are all verified by some appropriate entities, and any changes are completely digitally signed. Okay. There's a layered access, so we have a clear demarcation of public and private data. So private information in the simplest case for a doctor could be their private information such as their phone number, email, PAN card, etc. And we want to enable access to this private data only based on consent. We are starting off with a very, very minimal schema so that we capture only essential information that is required. But the schema is extensible by other players in the ecosystem. And all of this information, is accessible via public APIs. Maybe I should. Okay. And we want to be incentive aligned so that every player in the ecosystem is a willing participant in the registry. For example, if we start saying that we need doctors to enroll onto the registry, we need to also think through incentives for why doctors would like to participate in this registry. And unless things are incentive aligned in the system, we will not have it's not a sort of a virtuous self-fulfilling system, and things will break, right? So we sort of have a concept of a layer 1 registry and layer 2 registries. So layer 1 registries is what is managed by the government, some appropriate government authority. And this contains very minimal information about the doctors, for example. It could contain demographic information, what their qualifications are, and where they're registered, what registrations they have. And on top of this, you could layer other market participants can layer additional information. For example, what are the work hours of a doctor, what are their consultation prices, ratings, etc. So these are layer 2 participants, which are completely private participants, which build on the layer 1 registry. So we have a sample schema here of what information is captured in the layer 1 doctor registry, which is uh, going to be hosted by a government authority. And as I said, it's basically demographic information, some information like a PAN card, because you might want to do e-signatures, and we'll talk about why e-signatures are important, medical registration information, and medical qualifications or medical education information. Okay. So we'll now talk about the incentive alignment. As we said, incentives are key for doctors, for example, to come on board. And here we lay out, for example, some of the incentives for why a doctor would want to come on board. So one of the key aspects that we are thinking about is, for example, a e-sign of prescriptions, diagnostic reports, and discharge summaries. These are critical in various health information flows. One example of a health information flow where this is important is in e-claims, for example, insurance documents, right? So for insurers to verify that the doctor who is signing off on this are actually legitimate. This also enables you to get trust when a doctor participates in telemedicine kind of situations, because you can get a verified symbol in online apps, say your Practo app or whatever or the current Arogya Setu app, so that you get these verified symbols on these online apps, so that people trust that this doctor that they've discovered is actually a certified doctor. Apart from that, doctors have something called continuous medical education, where they collect what are called CME points online by attending various um, seminars, etc. And today, this is a very manual process, and these are required for them to continue to maintain their license. So they need to get a certain number of points on a yearly basis. So this can also be digitized. And there are there are a few other examples that we'll talk about. There's an EKYD, which is Know Your Doctor. And this sort of helps if for example, if an insurer is able to get your Know Your Doctor, it enables you to get sort of professional indemnity insurance digitally, right? These are all the benefits of the doctor registry. Okay. Given this, we'll walk through some of the APIs we have developed. So there are 3 classes of APIs we have developed. One is the enrollment APIs. So these are the APIs that allow doctors to enroll onto the registry. The second are the consented APIs. So basically, whenever information is required um, that reveals certain information about the doctor or private information about the doctor, these requires consent from the doctor. Examples of these could be the Know Your Doctor API that we spoke about and the eSign API we spoke about. And finally, there's a public information APIs. This is the ability to search and access public information about doctors. So you can go to the registry and search for a doctor by name. You can search for a list of doctors by certain kinds of qualifications, etc. So we'll move on to the enrollment APIs first. We'll first list them out and then we will walk through what we have released for today. So today, just stepping back, what we have released are the consented APIs and the public information APIs. Next week, we will be releasing the enrollment APIs. So the enrollment APIs, we have a bunch of them. First is the doctor enrollment API, where the doctor has the ability to come on board and register themselves with basic information about themselves, their qualifications, etc. Then we also have an alteration or an update API where the doctor can come, if they've got a new certification or a new degree qualification, they can come and update this information on the doctor registry. We have an enrollment deactivation API so that if a doctor is no longer active, we need the ability, for example, to deactivate the doctor. Then I'll just talk about the attestation APIs. So we have three kinds of attestation. Basically, once the doctor enrolls and gives certain information about themselves, we need to have agencies that actually attest this information, saying that these are verified. So there are three kinds of attestations possible. One is demographic data attestation, which basically says, are you really who you say you are? So this will be backed by either Aadhaar or PAN based verification. Then there's the qualification attestation. So basically, if a doctor provides certain degrees as certificates saying that they've attained these degrees, then we need to have the ability to attest the fact that the doctors have indeed got these degrees from the institutions they claim to have had. So this will also require us to have APIs that connect with the universities, which we will be building out. And there are, of course, certain nuances about getting degrees from Indian universities versus foreign universities, etc. And finally, there's something called the practice location API. So the practice location API is basically the states from which you have you have received the license to practice in, right? So the state medical councils of these states will attest to the fact that you have indeed got you got the license to practice at these locations. Okay. So the next set of APIs is the consented access APIs. This is something that we have released today. So what we have here is three sets of APIs. One is an authentication API. So this is used to verify that the doctor is indeed wants to give access to the information request. So this is typically an OTP based authentication that we are thinking about. Second is the eKYD API. So the eKYD API is basically the Know Your Doctor API. So what happens here is that when you send this eKYD request, the doctor first authenticates it. And once the doctor authenticates that request, then the entity that is requesting this information, it could be a telemedicine platform, it could be a hospital, receives a digitally signed certificate that says that this is the information of the doctor and this is verified by us. And on top of that, we have the eSign API. This is for doctors to e-sign prescriptions and claims forms. Finally, we have the search or public access APIs. There are essentially two APIs that we have described here. One is if you know the identity of the doctor, you have the ability to retrieve information specifically about the doctor. That's a very simple API. And another is a search API where you can search on this information using various types of fields. So for example, you can ask the question, give me all doctors who have a certain qualification, or give me all doctors who practice in a certain location, those kinds of things. Okay, with that, let me just quickly walk through some of the APIs on Swagger. So let me go up. Yeah. So this is our Swagger's specification of the APIs. We have the links in the presentation here. So we are starting off with the auth init API. So the auth init is basically when the entity wants to request for the doctor to authenticate the request. So you send the identity of the doctor and send an auth initiation request, right? And we have specified all the success codes, the error codes, etc. here. The second API is the auth finish API. So once the auth is, once the doctor, for example, enters the OTP, we specify the transaction ID and the OTP and send it back to the hosting agency of the registry. And again, the response is either the OTP that you've sent is whether it's valid or invalid, right? So this is the second API that we have. The third API that we have is the KYD init API, basically where you're starting the flow for the know your doctor. Again, here you're sending the information of, you're requesting the KYD initiation based on the identity of the doctor. And we have a bunch of messages for that and response codes, etc. specified. And next is the KYD finish API. So basically, once the doctor verifies the OTP or gives the OTP, you send the information back to the registry, and the registry comes back with a bunch of information, including the entire information of the doctor. There are two pieces here: the entire information of the doctor, both public and private, and we have a digital signature associated with it to say that this is verified information. So those were all the consented APIs. Next, we'll talk about the public access APIs. So as I said, one, there is a get info API where you provide the identity of the doctor. And once you provide the information of the doctor, you can go and get public information about the doctor. For example, what his degrees are, what his qualifications are, etc. And this is public information. No private information is returned in this call. And finally, we have the search API. In the search API, you essentially have the ability to query or search on a bunch of fields. So either you can search by the name of the doctor, you can search by um, uh, the qualifications, you can search by doctors with registered in a certain state medical council. There are a variety of requests that you can make based on a variety of attributes. And what we return is an array of the doctor's public information. So with that, I will stop and hand it back to Sharad.
So thank you so much. We would encourage you to ask questions on the link that is mentioned here. The reason we are doing it like this is because it gives us persistence of those questions. They come to one place and we are able to cover them as we go forward. So once again, a request, look at the chat box. There's a bit.ly link there. You can add your questions there and we'll answer them in the next session. So with that, let me hand it over to Sid. He's going to cover additional questions that came up on PHR since our last conversation. Over to you, Sid.
Thanks, Sharad. Once I'll just share my screen. Yeah. So a bunch of the questions that came in were what we had already answered in the previous two open house discussions. So I have not addressed them here. And so my suggestion is for the folks on the call to go back and take a look at the published videos to get those answers. It's also good to see that a lot of the new sets of questions that are coming in reflect that folks have started getting into the implementation details. And so I've just triaged those most important questions, and I'll run through them today. The first one is essentially regarding the open source code base that we shared with you guys. There are two parts to it. There is the open standard that's been published, which lays out the standardized interfaces between a gateway, a bridge, a consent manager, and then the respective HIPs and HIUs. And then there is a reference implementation of all of these interfaces being implemented, which is reflected as part of the GitHub link that has been shared. And so there were concerns around whether it's mandatory to use this open source reference implementation. Is it the only implementation that exists? Does one have to extend upon it, and so on? And the answer is very categorically no. It's not at all mandatory to use the reference implementation that's out there. The purpose of the reference implementation was really to ensure that the specifications that all of us are designing are implementable, and showcase a demo of them. And someone may, of course, decide to re-leverage that same code base and use it for their implementation by building wrappers around it. But if you are an existing, say, consumer-facing company and you want to build your consent manager, you don't have to use the consent manager app that's been published there. You can build your own against the standardized interfaces. Or if you are an HIMS/LIMS company and you're deciding to build your own API bridge with your own features, you don't have to offer the bridge. You don't have to use the open source bridge implementation that's been provided. And the same applies for the gateway. So I hope this clarifies that concern. The second was regarding the approach we've taken with respect to schema standardization, where in the first phase we said we're supporting a schema-less approach. In the second phase, we're supporting an embedded schema approach, and the third supporting essentially standardized schemas based on data dictionaries that get evolved. And so the question was, in the first phase, can an HIP share various other data formats like JPEGs and PDFs? And the answer is yes, they can. What we do expect, and there are a number of companies already building this middleware out, but what we do expect is in the first phase where you are sharing non-standard health information, and you're also sharing it in different formats like PDFs and scanned images and so on, we do expect a middleware ecosystem coming up on the health information users end that essentially takes in this information, is able to classify them into different documents. So depending on whether it is a diagnostic, whether it's a discharge summary, whether it's a lab report, whether it is a prescription, and so on. They may even go on to offer, in addition to classification, then extraction, right? So extracting the various elements from these documents and making that machine readable. And some of them even go to the next extent of codifying it. So matching the extracted elements with existing data standards out there, be it SNOMED CP, LOINC, and other standardized vocabulary related to grouping of different diseases and so on. So we do expect the middleware ecosystem to build out, and that's also an opportunity for a lot of folks to build out these classifiers, extractors, and codifiers during the phase where a schema-less approach is being adopted. But as the ecosystem evolves, we do expect standardized data dictionaries to come up. There's already a bunch of work that's happening in the space of diagnostic reports, and in our next call, we'll share a version of that vocabulary as well. And what that allows for is new systems as well as existing systems to align with these vocabularies. And hence it makes the interpretation on the HIU side even easier. And just an additional point is, especially if of course, let's say you're building out an HIU app and you don't have a middleware that does the extraction, transformation, codification. You can even build out a very simple app that shows all of those documents in a human readable, human interpretable manner back to the consumer. If it's a very simple health locker app that's just showing a longitudinal view of those records to the consumer, and it's not being consumed by any other third-party application. So that's also possible in the first phase. The next question is around standing / recurring consent. So can the consent manager give the health locker, who's acting as a health information user, a standing consent to keep pulling users' information from various HIPs on an ongoing basis, and essentially bypassing the need for the user to authorize consent every single time when he goes to the next test? So there are a couple of points that I would like to cover in that. One, the user can authorize, a consumer can authorize recurring consent, saying that for my health locker, whenever I visit a set of health information providers, please push my data so that it's available over the long term. However, the user can always go back to the consent manager and revoke that access. So you can never bypass the consent manager. The user has a choice to go back to the consent manager and revoke that access. Let's say if he is unsatisfied with the health locker service that's provided. The second part of this is a pull-based flow in the current architecture. And one can also imagine in the future a push-based flow where when I go to a lab, and at that point in time, instead of giving, say, my email ID to the lab, I can just give my consent manager ID, and the lab then pushes the test results when it's ready, and it straight away gets sent to the health locker that's linked to that consent manager. We have not spec'd out that flow, and for the folks that are interested in contributing on that, please do reach out. But that does improve the user experience a lot versus a pull-based flow, which is part of the current architecture. The next question is, can the API bridges be configured such that instead of just sending the links to the information based on a request, the information itself can be sent? So if you look at the APIs currently, what happens is they're completely async, and essentially the HIP notifies once the data is ready and notifies the health information user that this data is ready and is available at this corresponding link. Then the health information user can go to the HIP against that link and fetch the set of relevant records paginated accordingly. This can evolve. What we do expect, again, enhancements to this, if you look at it from a futuristic point of view, where you could even have multi-party streaming of this data. As the data sets get heavier, then you can use, and that's where the bridges can come in and really innovate on multi-part uploads, and how do you do that in a very timely manner for the larger health data sets, or when you're sharing larger images and all of that get associated. The next question is regarding encryption of the consent artifacts. So if you look at the flows, the artifact is generated by the consent manager. The respective consent manager then digitally signs that artifact right? And that digitally signed artifact is transferred over an encrypted channel using TLS to the respective HIPs and HIUs. And as a result of that, you prevent man-in-the-middle attacks from reading the consent artifact while it's in transit. And second is the respective HIP and HIU can verify that consent artifact and validate it since it's digitally signed by the consent manager. And the last question was regarding the health identifiers. We've addressed this before, but it's an important topic, so I just thought I'd answer this one, which is there a unique identifier that's used across the entire system, PHR system, a unique health identifier? And if not, how do you allow for discovery of multiple health identifiers? So first, a unique identifier is not mandated as part of the system. So if you look at the APIs, there is a standardized discovery protocol that has been defined. So a user can go to multiple providers and they may happen to use different IDs. In provider one, they may use like a lab, their PMJ ID. And then when they go to a clinic and the clinic is not part of PMJ, they may actually give their mobile number plus demographic details, name and gender and date of birth and so on, right? And then go to a hospital and the hospital has its own provider ID that they decide to issue, right? So when the user registers with the consent manager, and of course they can be assisted with this process depending on the user segment, through the consent manager, because of the discovery protocol that has been standardized, the user can actually discover where all their data resides and then link with each of those respective health information provider accounts. So I can give my PMJY ID to my consent manager and then discover all the providers where my data has been linked against my PMJ ID. Or I can provide an authenticated mobile number and my demographic details to the consent manager and then discover where all my data was linked with those respective identifiers. And then the HIP authenticates me to authorize a final linkage between the HIP and the consent manager. So therefore, through this mechanism, you can discover across a range of identifiers, and this also preserves anonymity of the user in certain health transactions. The second part of it, and the first part, what I just covered, is relevant for, say, historic data. And the second part of it is, let's say as a user, going forward, I just want to use one ID, so it's easier for me, just like your mobile number and email ID. So in this PHR paradigm, that becomes your consent manager ID. And so the next time I go to a lab or a clinic or a hospital that is using an API bridge to make your data accessible through the system, you can just provide your consent manager ID. So you could just say, my ID is Saurabh at consent manager 1 or Saurabh at CM at the rate of CM. And so whenever that data is ready, whenever that data has been published, it gets published against that ID. And so you'll immediately get a notification through your CM that this data is accessible. If you've linked it with a health locker, then you can push it there for long-term storage. But through that mechanism, what it ensures is that in all your future health transactions, your data gets auto-discoverable. The last question is there any defined or recommended timeout for the data transmission from an HIU to the bridge to the CM to the HIP, and then between the HIP and the HIU? This is actually a very good question, given that the flows are completely async across the entire ecosystem. We haven't yet, and so we do expect to design a circuit breaker mechanism. We haven't yet defined the timeouts because, and we left it configurable because you have to factor in, depending on whichever timeout you choose, you have to factor in false positives and you have to factor in latency as well, right? And then choose where on the spectrum Is that something that all the entities agree with? And so we haven't yet defined it at this point in time. So I don't have an answer actually on what the recommended timeout would be. And if you are interested in helping us define this, then please do reach out. We've now got 4 working groups that are active. There's one group driving the technical architecture side. And so essentially the circuit breaker timeout question and what would be that right variable fits in there, along with various extensions to the architecture. There's a second working group that's driving efforts on the data dictionary. So essentially moving towards, moving away from schema-less and moving towards a standardized data vocabulary using existing standards plus variations to suit the Indian environment. The third working group is essentially the pilot, where various folks have reached out and already started building different components of the PHR ecosystem, API bridges, consent managers, health lockers, and so on. And so if you're interested in building and being a part of the pilot, please do reach out. And then there's a last group that's looking at the incentives across the ecosystem, monetary and otherwise. So far, we haven't yet covered the monetary incentives. And so once the working group's ready, we'll actually share that with you guys in a subsequent session. If you are interested, please do reach out there as well. That's it from my end, Sharad. Yeah, over to you.
So if you can go to the next slide, Sid, if you don't mind.
Okay, sure.
Yeah. So with this, we come to an end of today's session. What we are going to be doing next week is covering 2 topics. We'll come back to PHR this time, focus specially going deeper for hospitals. And we will also talk about the doctor registry enrollment APIs, which Vikram talked about a little earlier, and we didn't have the time to cover them in detail today. So we'll be covering them in detail tomorrow. Please do note that next week's session is at a different time. It is at 9 a.m. It is not at 11:30 a.m. So do note this. The reason for this is that, we were doing a separate kind of a private session, PHR for hospitals, for Healthcare Information and Management System Society, HIMS. And then we thought, it's best to merge both together, because what we discussed there would be of use to this audience as well. So we merged the 2 sessions, and that is why we have a different time slot. Also keep in mind, we want to tell you that we will not be doing a session on 20th of June. We'll be taking a break on 20th of June, but coming back on 27th of June. And the 27th June session will be an important one, because that is where you will get information about the test environments, both the doctor registry test environment and the PHR test environment that is going to be launched on the 30th of June. So this is an upcoming set of sessions that are there. So with that, thank you to all the panelists here, lots of iSPIRT volunteers who work selflessly behind, the faces that you see in this panel, and a special thank you to all of you for participating. So with that, happy building. Have fun. Bye.